Hello everyone, I'm Manuja Alpha, a first year clinical fellow. I start today the EGM Conference. This is today's ECG. There's no more information. Oyuka, will you start first?
I can see regular tachycardia, broad response tachycardia, initially like witty. Okay, some of the waves are buried in. I can see the capture fusion beat.
Which one? You can point and it will follow.
This is the initial
Follow the mouse.
It's the narrower than previous beats. So these are and those are narrower than the previous one. So also, if you can look at carefully, there's also the same morphology of the you can see. Also, this is also different.
So you favor BT.
VT. If it's VT, it's RBB morphology, comes from left side, and inferior leads are positive, it's LV basal lesion. So lead one, ABL is positive, comes left side, LV, maybe LV subclinical origin or LV of NCC origin, but the rate is more not too high. But it could be some aberrancy. Maybe the second point is it could be some aberrancy is ongoing here, but more likely my diagnosis is more likely VT.
Okay, very good. So your first choice, BT, because of fusion beat and dissociation. Okay. Dr. Che?
I think we are not in the wrong right Zoom.
줌 인비테이션 보낸 거 딴 데로 지금 들어가고 있는데.
내일에
이렇게 연결의 문제가 누가 보낸 거예요?
내일은 제가 보냈었는데 항상 보내던 링크로
누가 안 된다고 보낸 거야?
제가 그냥 아무도 접속 안 했길래.
접속해보니까.
내일에서
라이프 아파 저기 하는 거는 준비는 됐어요. MPJ 해야지. 이거 하면서 같이 해.
똑같은 건
고내용이 대부분 질문에서 나오고. 근데 라이팅 할 때 처음부터 나가 얘기했지. 근데 헷갈리거든. 처음에 프라임 오브젝티브가 어블레이션하고 공백이기 때문에 어때? 어쨌든 색한 자리하고 전체가
그걸 둘다 오버롤이랑 발달자도
테이블 딱 보면 볼 수 있게 테이블에서 그냥 그래프만 보여주면 헷갈려서
메일에 보낸 링크를 들어가 그 메일 링크로 지금 접속한 거
됐어요.
네, 그 링크 똑같이
누가 보낸 건데?
강세영 선생님
아니 지금 장난가 그냥 들어가고 뭐야?
예, 똑같이
근데 안 돼?
네,
접속이 안 돼?
제가 회의 시작을
근데 아까 황준 선생님도 들어와 계셨잖아.
다시 나가면서 레코딩을 하고 스탑 레코딩을 하고
지금 인스트럭션 파일이 있어요.
근데 왜 이렇게
오늘 좀 제가 했던 거. 인스트럭션 파일 올해 초에 제가 만들어가지고 매달 초에 다 공유하고 있습니다.
내가 좀 일찍 와서 안 되는 건데 해야지.
네.
예전 뭐 맞나요?
네, 또 하겠습니다.
아니 아까 뭐 처음에 다 못 들은 거 아니에요?
다시 시작했습니다.
다시 시작해야 될 거예요.
네. Hello everyone, I'm 원우장. First year clinical fellow. I will start please EGM conference.
미안하다고 얘기를 해야지.
I'm sorry for being late. There was a problem. So
프로그램.
clinical problem.
예.
Please.
보인다리, could you please? You're ready.
Okay. Okay, now you can see the different morphology corresponds tachycardia. So also we can see the VA dissociation of this ECG. Although bottom middle of the lead to
마우스 따라오세요.
we can see some actual beat and vision beats. It's more likely ventricular tachycardia. So this initial regular cross complexes, and now we can see the different and narrow cross complex beats, and also hair beats also different. The PV fuses on this cross complex also appears different. PV, and also PV can see this B on the speed, so more likely VT. So RBB morphology and inferior axis, so more likely left ventricular basal region. So, and lead one ABL is positive, comes from left to the right side.
레코딩.
네, 지금 레코딩 됐어.
Okay. Very good. Dr. Check.
I also agree with Uyuka. Actually, it is about 100 to 150, and there is a P wave, but it is dissociated with the QRS complex, and also there is a fusion beat. And in the precordial lead, the concordance is positive or positive concordance, and when we localize the VT origin, RBB morphology and lead 1 and ABL is negative, so it is come from the left side, and inferior lead positive, and or positive concordance in the precordial lead, so maybe summit, probably summit, anterior basal area, so that's right.
Okay, 상호.
Yeah.
Tell us your opinion against previous two interpretation.
Actually, I agree with two ladies, but we can confuse with the RBB with the VT pattern. Obviously, there's RBB pattern, but I want to show the contra. I want to show the different opinion from her, but there's definitely no man's land axis northwest, and there's P and QRS dissociation with it.
Northwest.
I mean from the left. So
Going to southwest.
southwest. Yeah, so I agree with the VT also.
Okay, copy. Flip the. Yeah,
So I think there might be two things going on. So first is when we look at this side, we see broad QRS rate of maybe around 120 with a 1-to-1 QRS to P relationship. We see, I think these are retrograde P waves. This rate is not very fast, so I'm tempted to think this part might be an accelerated idioventricular rhythm because I don't think it's faster than 120 milliseconds, 120 beats per minute. Then over here, we see that the P wave shifts a bit, and then we have a narrower QRS with a sharper intrinsicoid deflection. And the rate increases. So we realize that over here, the rate is maybe about 140. So 1, 2, 3, 4, 5, 6, 7, 8, 9 beats. The rate is faster. Initially, we see that there is some dissociation, but then it stabilizes, and then we have the one-to-one relationship again. And then we have this over here. Axis is a right axis. So I'm not sure, but I think this over here, there's a fusion with the sinus rhythm. Here we have the idioventricular rhythm. It fuses with the sinus rhythm over here, and then there's a tachycardia. As we go on, the rate slows down, the fusion ends, and the QRS broadens again, and back to the one-to-one relationship. So I'm not sure how to summarize what I've said, but I think there's an underlying idioventricular rhythm that fuses with the sinus rhythm, goes faster, and then slows down back to the ventricular rhythm again.
Okay, Dr. Wang, any comments?
No, I agree with
So,
Coffee.
SVT?
No.
Idioventricular rhythm?
Interventricular.
But I think it is unusual, the intrinsic deflection time is very short, right? And the QRS width is prolonged and shortened depending on the heart rate. So I saw this type of ECG in patient who has the antiarrhythmic drug toxicity. So we need to, even though the ECG criteria favors VT, but we need to see that there's some drug effect. And another interesting finding is if it is monomer VT, it is too irregular hour interval. So we need to think about the both sides. Any other comments? Dr. Wang?
Yes, sir. How are you?
Yeah, very good. I'm happy to hear your voice. And we collect the fellows and faculty's thoughts. And please conclude this ECG.
So clearly patient has a very irregular wide right bundle morphology VT pattern, but question you have, Kofi said that there's a retrograde P wave first to 6 bit. I am not sure I can agree with that. Is you have to tell me then, let's say last 1, 2, 3, 4, fifth bit of the last complex. Yeah, there's a notching, and then right at that one, and then following another sharp peak there. Which one is the P wave then? They're both P wave?
Second one.
Second one. That notching, the first before, right after the QRS complex, what that it is? That's a P wave too? Or that's a part of a QRS complex? That I think as an answer lies on, okay? Because if you look at that notching timing, it is slightly changed with the QRS. And then under if you measure that, maybe, second one should fall between the RR, but it's not. So I am not sure that is a P wave. P wave, maybe what you see is that 1, 2, 3, 4, 5, let's say fifth bit of 6 bit before there's no retrograde right at next beat. There's no notching after that. And then you have a small notching preceding narrowish complex conduction. Looks like that's a capture beat. Go to that notching just 7 beat before. These two, go there. There's a point arrow. Yeah, that guy. A little bit to the left. That notching, small notching before the QRS become narrowish. Yeah, that one, yes. So that maybe explain why the QRS became narrow, okay? But also rate increases, as the coffee says, but it's still irregular. So how can sinus rhythm behave like this? So that possibility could be opened up, could be maybe atrial activity of fibrillation, or some sort of a fast atrial flutter with a varying degree of a conduction block. Is a possibility we have to raise because RR interval is irregular due to the fusion. Okay? Because if you look at the tracing, why the complex is fairly steady. Okay? Then suddenly narrow down, start become irregular faster, and then once that stop, back to normal. So there's a maybe, like Kofi said, that the two rhythm going on. One is maybe slow AIVR type of a picture with the atrial arrhythmia overriding intermittently your AIVR, causing these alterations. Since we don't see clear-cut P wave, but I see multiple P wave, can be Dr. Box says drug effect. Yes, maybe if you slow down atrial fibrillation with antiarrhythmic drug in the presence of AIVR, maybe you can see this. So I think there's a two independent activity going on atrioventricle here. Other possible explanation is what? Can ischemia do that? Ischemia.
Yes.
Yes, I think we have to.
Yes, we always,
Yeah.
you cannot exclude ischemia. Okay. Beside the drug. Okay.
Yes.
Okay. Tell me what's happened now.
Yes. This patient was a 50 years old man at the time of event, and he experienced sudden cardiac arrest at around 3 a.m. And the total arrest
Oh,
time
boy.
was 40 minutes, and the total CPR time was 24 minutes. And
Mhm.
he had a history of gastric cancer and had undergone surgery at Seoul National University Hospital 5 years before this event. He had no significant family history and was not taking any medication. Regarding his social history, he had a 35-year smoking history, and he drank alcohol 3 times a week, approximately 3 bottles of makgeolli each time. At
Okay.
3 and 3:10 a.m., he was having a normal conversation. At 3:36 a.m., emergency medical service were called, and bystander CPR was initiated. And the initial reading was ventricular fibrillation. He received 4 defibrillation shock and subsequently achieved RSC. After RSC, he was able to obey command. So this ECG was obtained after RSC, and
I see.
cardio version was subsequently performed, and this ECG was obtained afterward. And the test X-ray showed pulmonary edema and cardiomegaly. PT showed that there was a mild hypokinesia of both the left and right ventricles, and the left ventricle ejection fraction was approximately 45%, and coronary angiography showed no significant coronary arterial disease. And EP study was subsequently performed, and the epinephrine provocation test was negative, and ventricular tachycardia could not be induced. And a left posterior lateral accessory passage was identified and successfully ablated. Finally, an ICD was implanted for secondary prevention, and he's down.
Hang on a second now. Why did the ICD implantation? I'm confused now. So can you go back that sinus rhythm ECG after shock? Yeah, that one. How many of you see delta wave here? Anyone see delta wave here?
Maybe CBT considered bypass, right?
No, concealed bypass would not cause a VF arrest. Has to be pre-excited. Post-receptal, typical.
Probably instantly found Right, that's right.
No,
Please.
no, I think this is, you don't have any other ECG of a sinus rhythm, this patient?
Oh,
Because it's right after shock, his sinus tachycardia, right? So if you have a minimally pre-excited post-receptor X-ray pathway, you will not see delta wave because it is a competitive, too close a AV node. As I told you before, among the WPW, one that causes most VF arrest is a post-receptor. Then also one of the most easily missed by quick EKG readers. So it is something that you need to keep that in mind. But certainly the presenting EKG did not show evidence of a delta wave anywhere. So I think that's just a drug effect of a resuscitation, whole 9 yards. I think that's what's happening. Part of a hyperkalemia combined together. So, yep. I've seen so far in Korea, this is a number 7 patient post-receptor WPW patient at the VF arrest. Okay. So be aware. So it's there out there, especially P guys. Okay. Well, I'm glad that you guys did the EP study of late. That's a good thing. And then I'm just not understanding why you need to put ICD on this patient. What was the rationale? How come sudden cardiac death? The BFRS, we are assuming because the patient had probably pathway related to tachycardia. You did not induce a VF with the pathway though, right? During the EP study. You induced tachycardia, but that did not generate into the VF. But you saw inducible sustained atrial fibrillation with the augmentation of delta wave. So I don't know whether I would put ICD on this guy. His ejection fraction, echo was just enlarged a little bit obstructive function, my understanding, correct? 45% down because you did after the CPR, all that. How soon after the CPR did you do echo?
same day.
Same day, no, that would not give you a good normal ejection fraction assessment because you still had a stunning going on. So to truly reflect the patient's baseline ejection fraction, you should wait the 48-hour or maybe another 72-hour that would do echo, then you don't have a rush into the ICD implantation. Then let's assume that this patient become more normal, okay? Then would you put ICD on this patient? That would be the question. The reason we're discussing this is that the defibrillator is a life-saving treatment. Yes, it is. But on the other hand, if you look at any larger trial, truly positive appropriate shock versus inappropriate shock percentage is about the same. So this is a young man, so you tended to have a more inappropriate shock based on the age tendency, because the shock can cause a lot of mental disorder, like a post-traumatic syndrome. And I have many patients like that. So I had to take it out some of the devices, some of the patients. So it is something that you need to, as your clinical practice grow, watch it carefully. Because you done cardiac cath, you did the ergonomic test, you did everything. You can find nothing wrong. He does not have any other marker other than a drinking problem, smoking. That does not mean he's an increased sudden death risk. And his ejection fraction is above the 40%, 45%, even after the cardiac arrest. So this ICD implantation is something that obviously not written anywhere, but it is a clinical sense that may not need it. So that's something you think about. Okay? So don't rush to put the patient ICD. You ablate it, wait, reassess a few days later, then take a look at it. See what it does. And then other thing that because he has a diastolic function, sometimes it's worth doing treadmill exercise testing. Okay? Physical exercise testing, I'm talking. See whether you do have some reproduction abnormality, some other issue. Other than that, there's no functional data here, so you can tell. Okay? That's what I would have done. ICD implantation, probably I hold on for at least 3 days or so. Dr.
I
Bob,
don't
think.
Yeah, I don't know how did one to find out this case 12 years ago.
Actually, this is Professor Hwang's patient, and I saw this patient in device clinic, and
implant?
Which one you talking? My patient?
patient because I found
12 years ago. which doctor?
So which one you talking?
women one. There was woman one.
So the 12 years ago, he was a
Student.
medical field.
To be honest, I mean, when I in device clinic, I just look for the information.
That's the story.
Yes. But I mean, there were only inappropriate shock for the IC report. So I was curious about.
So if the
Yeah.
patient experienced cardiac arrest because of pre-excited AF, ICD implantation is actually class 3 indication. So catheter ablation class 1. Okay. So even though the ejection fraction was a little low, we need to wait 1 or 2 months, then repeat echo. If it is fully recovered, this patient doesn't need ICD implantation. That's the message that Dr. Wong said. And I wonder, because he's a heavy drinker, even after stomach cancer surgery, so I wonder he already had atrial fibrillation and have been taking the antiarrhythmic drug. So please review the medication. Yeah. Okay. Any other comment? Yeah, because of technical problem, we started a little delay. I apologize that. And
Oh, you're still on time.
Hmm?
Yeah, still on time, Dr. Bach. 4 o'clock. My time. So you're 8 there.
Oh,
Yeah.
I see. Okay.
You guys done well. No problem.
Okay, let's move to EGM Conference. Thank you. Recording off.
Good morning, everyone. My name
Is it sure? It doesn't have the green boundary.
Share one, right?
The left one.
Left.
No,
No,
yeah, that's okay. Screen share. Yeah, that's okay too.
My name is Oydre. I'm fellow at Silver's Cardiovascular Hospital. Today, I'm going to present a case for progress. So, our patient is 67 years old male who presented with palpitation. Each episode lasted 2 to 4 hours. The typically onset during sleep time. Palpitation persisted for 3 to 4 hours before came to ER. Recently, palpitation frequency increased to 2 episodes per week. His past medical history includes hypertension, variant angina, and known of orthodromic EVRT. He's using those medical drugs. So this is ECG in April this year was normal sinus rhythm, prolonged PR interval. Chest X-ray was unremarkable, and heart CT was showed minimal coronary artery disease and multiple solid or subsolid nodules in right lung, which is favoring benign. So his echo showed borderline LA enlargement. The size was 41 to 43 millimeter, and preserved left ventricular systolic function, EF65, relaxation abnormality pattern. So he would already had EP study and attempt ablation at Chongwon University, October 2025. This time, accessory pathway was adjacent to his bundle, is carrying a high risk of AV block. So ablation was deferred. He was managed medically instead. Unfortunately, we didn't save our initial catheter position X-ray, so I just wrote it down. We used the dual-decker catheter at CS and low RA, one quadrupolar catheter positioned at RV, another one at his bundle. So here's the tachycardia ECG of the patient in the during the EP lab. You can see the narrow QRS complex, regular tachycardia. So here is the baseline EGM parameters. Cycle length was 958 millisecond, AH 93, HV 67, QRS duration was 91 milliseconds. VA block cycle length was observed at an RV pacing for 160 milliseconds. VA conduction was non-decremental. ERP was observed at an coupling interval of 240 milliseconds. AV block cycle length was observed at RA pacing for 100 milliseconds. AH jump was observed with isoproterenol 3 microgram minute during single AST test, coupling interval of 260 milliseconds. AV node ERP was observed with single AST test, 600, 310 milliseconds. ERP was observed with single AST test, coupling interval of 240 milliseconds. So tachycardia was induced during the test with ISO 3 microgram minute during double AST test. Here is the patient's tachycardia surface ECG. So tachycardia measurement was cycle length was 367 milliseconds, AH 221, HV interval 69, and QRS duration was 93 milliseconds. V reset was positive, and V entrainment PP minus TCL is 87 milliseconds, which is less than 150 milliseconds. We did parahesian pacing. It was extranodal response. High and low output stimulus to A interval was stayed constant. During RV pacing, mapping showed the retrograde airlift A was at his 1-2, and a accessory pathway bump observed during mapping. Now we can see there is a bumping point. As a summary, to AVRT induced by doing double AST test with isoproterenol, earliest retrograde atrial activity at his 1-2 during RV pacing. There was no VA decremental property, and V reset was positive. V entrainment was less than 150 milliseconds. Parahesian pacing, stimulus to A intervals are constant, which is based on this impression. Our diagnosis was orthodromic EVRT, parahesian origin, anteroseptal accessory pathway. Given these findings, here's how we approached ablation. The arrhythmia focus was located very close to the His bundle. Ablating directly at the His bundle area would carry a high risk of causing complete AV block. So instead, we approached through the aorta and ablated from non-coronary sinus. Before ablation, we performed aortogram to confirm anatomy. Whereas the non-sinus aortic aortogram showed. Here's the ablation signals from non-coronary sinus. Here's the 3D map during the ablation. So we noted his by yellow color, and the pink colors are our ablation points, and this one is the end point of our ablation. So after fifth time of ablation, we successfully eliminated accessory pathway. Here is the patient post-ablation EGM. After 20 minutes later, VA conduction became decremental. This was our ablation endpoint, and also no inducible tachycardia. Here is some information. The coronary aortic sinus is clinically considered an atrial structure, as it shares a relationship with both the right and left anteromedial free wall. So does it represent an anatomic vantage point for the anteroseptal aspect of the right and left atria?
including the parahesian region above the membranous septum. These fluoral images, the aortic angiogram, show the relationship between the non-coronary sinus and his bundle catheter. So ablation from the non-coronary sinus provides an effective vantage point to the superior paraseptal region while minimizing the risk of complete AV block. This is possible because the non-coronary sinus is anatomically adjacent to the his atrial tissue above the membranous septum, where the his bundle and AV node are safely positioned beneath or inferior to the ablation target. Here is the patient post-ablation day after ECG. So also sinus rhythm with prolonged PR interval and no other abnormality. So thank you very much.
Any comment and question about Dr. Wender's presentation?
I have 3 questions.
Oh.
Can you please go to the first ECG?
First sinus.
Yes, beginning of the sinus. So first question is, with the history of
Hypertension.
recurrent palpitations during sleep,
During, mostly.
yes, that was the clinical history.
Mhm.
With this ECG, looking at V1, would you be tempted to perform provocative tests to look for Brugada? The ST, I don't know, it's not typical, but it seems a bit rounded, and I'm just wondering if it would make clinical sense to consider Brugada with the history of palpitations during sleep. That's the first question.
Mhm. We didn't perform any provocation tests.
Well, the patient that doesn't feel chest fluttering, they. Good point.
The second one is at the beginning of the test, the HB interval was 69. That's quite prolonged. Was there any?
This is the A. This is the H.
7 HB.
HB.
I don't know whether
This is onset
the
of
measurement
wave.
or whether it's actually prolonged, and if there was any abnormality in HB conduction during the study, any rate dependent changes.
No, it's not changed. Yeah, actually, also the after ablation. Oh no, tachycardia, HB interval also 69.
Yeah, so I also carefully observed that, and the AV block cyclins was 400, right?
Mm-hmm. Yes.
The low DRT 320, 320.
The last question is to the senior faculty. So in a case like this, would it be especially for those of us who are inexperienced, would it be advisable to do this purely as a 2D procedure, or it's better we 3D map and tag the his before we ablate? Which would you recommend?
Because this patient has a high chance of block, I prefer to use 3D mapping, especially with the case. We experienced a similar one, and I will ask of the yesterday case to Dr. Huang after discussing this case, a different case. So, but at the time, already bicaster was damaged by previous ablation, so we easily bump up. So 3D is useful to tag the potential target site, and we can go back to the site and ablate. So I prefer to use 3D, but I don't know. Dr. Wang is expert. Probably he will use only 2D.
Thank you.
Before 3D, high density mapping was not available. We usually do 2D ablation. Okay, any other question? Can I see the ablation signal? So there is A and B, right? If it is non,
It's during the RA pacing.
ablation signal. You see the A's, local A and local B, even though the ablation catheter is above a cassette, right?
Right.
So if it is a real non-current cassette, they should the A local signal predominant, almost no B. So in other words, this location is probably close to NCC and RCC in between, because that area is an annulus area. But it is very dangerous area because of the commissure between NCC and RCC. Just below, there's a left side distal. So that's why the previous paper was recommend to ablate from the non-current cause. I don't think the bypass track is on the non-current cause, but if you ablate above valve, catheter is very stable. Okay, so energy penetrate the valve and may ablate the bypass track, parasitic bypass track. But I don't know the operator map the left side also. We need to map right side, left side, and cause.
First of all, we tried to ablate from the right septum, but it was very close. So, yep, therefore we changed our approach to the left side. So,
but not you didn't map the left side.
Left
just
side.
The coronary cusp first.
Yep, just coronary cusp area. Didn't fully mapped left side.
If you want perfect mapping, probably need to press the left side septum.
Also, yeah.
Okay, any other comment? Just a single burn. Did you eliminate?
No, we did 5 times of ablation.
So why did you burn 5 times?
The first was we tried to ablate right septum area above 3 seconds, and we shift to the left side 4 times.
Why 4 times in the area?
I don't know.
Usually, anteroseptal pathways, you want to get rid of first or second burn. Dr. Bak keep telling you that there's a close proximity to the conduction system. So next question I have, why are you pacing atrium? Do you know why? Why are you pacing during your ablation or mapping?
And it can help us to see the clear AVA potential during the ablation. If we can correctly reach to the non-coronary cusp area.
That's the wrong answer.
Oh, okay.
Okay. When you're ablating anything, AVNRT, axillary pathway, whatever, close the compact node, you want to burn, make sure there's no junctional rhythm or PR prolongation. So you have 2 options. In this case, a concealed pathway. Therefore, you could pace atrium, observing AHV interval while you're ablating. So to make sure they don't prolong. Okay? Other option is ablate sinus, there's junctional rhythm, then you have to pace. Stop burning and pace and then burn. Okay. Now you said there's a BA was a decremental. Can you show the EKG for me?
The first one?
No, after the ablation, you said the BA decremental. You wrote it in the top, didn't you? Keep going, B pacing. Okay, no, B pacing. So A pacing, go to B pacing. After the burn, you finish the case, you waited 20 minutes and then you paced, right? Okay. What do you think about this spacing? Can you say via decremental here? Yes or no? You need to be careful when you look at things. I would read as a VA dissociation, not via decremental here. Okay? Anybody disagree with that? Your P have no relation whatsoever with the pacing spike. Okay? And P of activation of sinus. If your pacing ventricle should be VA conduction, should be retrograde. It's not. That's wrong. So VA dissociation, you should write. Okay? Next time, measure PP interval, make sure careful on that. Okay, let's go to the case. Let's make some educational comment for you guys. So, okay. So, I mean, history-wise, I think is okay. The question is that why the 63-year-old guy suddenly have a lot of recurrent tachycardia. He was born probably with WPW, I assume. Correct? You don't acquire WPW after the birth.
They didn't
Yeah.
mention about that.
Okay?
Mhm.
The question is that whether he have been having this problem because he's developing, all other trouble and he's developing this, or this is something else changing. But 67-year-old guy, first, a few episodes of tachycardia starting later age. Clinical evidence suggests that maybe there's a second tachycardia. You just make sure that that's not happening. Okay? Sometimes you ablate pathway and patient come back with an atrial tachycardia, flutter, whatever, you're going to end up having trouble to ablate again. Okay, that's a clinical comment. Next. Go to the next slide. Yes, EKG wise, as a COVID telling you, PI is prolonged. Okay. Certainly there's some notching in the V3 also. That's an artifact from the cardiac contraction. I don't think that's worry about it. But the PI is not normal, this guy. Okay, keep going. Let's go. Chest X-ray looks okay. All right. But this guy doesn't exercise, it looks like. He has no muscle mass in chest X-ray. Okay. And then what is it that nodule about? Is he really benign?
What?
That's a long nodule. You said there is a lot of lesions, intermediate lesions, whatever, in the right pulmonary territory, right?
Right.
So is a CT scan read as a nodule, benign nodule?
Benign.
Yeah.
They need to benign.
They said it's benign. Can you be 100% sure just by CT scan?
No.
No, so then what you're gonna do?
They also repeated CT scan the last month.
Last month. So how long do you observe this kind of lesion?
No abnormality was. They noted also no abnormality, no consolidation of pulmonary.
Okay. But you still has a nodule though, right?
Nodules.
Yeah. So if you see patient like this in Mongolia, how soon you follow up?
6 months.
6 months CAT scan. Yes. So you need to make sure that you discuss with the patient. Okay. Okay.
Yes.
Next. Keep going. So anything else beside that? Okay. You already know patient had some sort of anterior subtaxillary pathway, something like that. Okay. Next. Okay. So you put the catheter in. Okay. So then you consider with the tachycardia? Do you see retrograde P wave? Yes,
No.
you do. Lead 2. Bottom. Yes. What is the RP interval there? How long that is? And you're eyeballing.
1, 2, 3, 4 small boxes.
More than 80 milliseconds. Right? That favor for AVRT, not AVNRT. Okay? Second, well, how about the PVX? No, you're too fast. Slow down. What's the PVX looks like?
Retrograde.
Negative?
Negative.
Slightly negative. How about the left side? Would it be negative like this? Left side pathway. You haven't paid attention, huh? So next time, please compare. They are different. Okay? All right. So that's your homework. You go take a look. Okay. Next slide. Let's go. So there's nothing really abnormal. That's just, but what I'm assuming that based on your CS EGM, perhaps 7, 8, 5, 6 is ostium. 9, 10 is not in contact. Okay? You didn't show us the chest X-ray, so I can, as fluoroscopy image of the catheter. But I assuming that the good contact I can see starting 7 and 8, 9, 10 is a far field. Okay? All right. HB slightly prolonged, that's fine. Okay, keep going. Now it's go to V pacing next. Yes. What do you see here? Do you see his bundle where? Do you see any his bundle? And you're tracing? You don't.
Yeah, it was so
This kind of pathway, you want to absolutely have a good his bundle potential with the B pacing or A pacing. Okay? Just for teaching. Next time, pay attention to that. Worst comes, you have to hold the catheter until you're sure what you're doing. Okay, keep going. So here, measure. So
Yes,
you have you're measuring pacing stem to the A here. Is that make sense? If you are measuring decremental conduction, when we measure from the stem to the A, that's what I'm asking you. Answer is no. You got to measure local B to the local A. Septum. You see a septal, right? Septal V. You don't see retrograde P, I mean his bundle here, but then you measure that whatever point, let's say his 1.14 have an initial negative point from B instead of V. That's A. V. V. Come back to the left. Yeah. You measure from that to that. Next one measure the same way you measure. Because the stem to the V can be also decremental. Then you'll be misleading. Okay? All right.
Okay.
Let's go.
Yes.
And here, what do you see? Can you tell me which one is A here, which one is V? You see his bundle probably, but all superimposed. That small notching, 3, 4, between A and B is his. Come to the left a little bit. No, same channel. You 3, 4. There is 3, 4. His 3, 4, please. Come, next, yeah. Come slowly left, very slowly. Keep coming, right there. Okay? That's your his. Retrograde his. It's fusing. Okay? Non-decremental. And then look at your 3, 4 channel sinus. You got good his bundle potential there. So always look for sinus rhythm, best his bundle potential, and you look for retrograde his. Okay? All right. But my point here is that, no, go back there. Your CS proximal, 7, 8, activation time to the his A is not, that far away in terms of, especially during the tachycardia when I looked at it. So that already hint toward to you that this is maybe some left side of the insertion input. So I'm going to send you an article written by Edward Blackwell. Okay? I want you to read it. He talk about this. Okay? All right. Keep going. Because you're here to learn, so I'm going to send you an article for you. Okay? That's fine. Keep going. Okay? Keep going. So you did the 3D mapping, right? Let's take a look at that map. Go, keep going. Show me 3D map. Okay, so you said the red dot, yellow dot is ablation dot? Or
Yellow is his.
His, okay. Red dot is ablation dot.
Yes.
Right?
Right. The pinks are ablation dots.
Right. How come that red dot is not where the white point is? You see that white mark in the activation map? Come to the lower. Yeah, no, come back. The white area. Yeah. In that early site? Did you guys look at the map after you created your beautiful map or not?
No.
Why not? What's the use of 3D then? That's what I was asking. Why did you burn 5 times? Use of 3D is to look at the map, confirm your EGM, identify the site, and select the best EGM in 3D. Sometimes 3D could be wrong, so then you do correct your map. This is you could have to have it, okay? So even look at your right side of the picture. Your red dot's not even close to white area. Okay? So you need to learn how to interpret this 3D. Second, next time, if you're going to make a 3D map, please map an entire aortic cuspid. You don't want to create only non-coronary cuspid. That doesn't work. That's the early question Dr. Park asking. Well, how come you did not create a right coronary cuspid, left coronary cuspid? Because you're learning, you're in training. And I think your ablation site could be right coronary cuspid. Okay? It's more medial, and so also a little bit more left side.
Can I ask?
Professor Huang,
Yes, sir.
this is my case, and
Okay.
we didn't use 3D.
So where did this come from?
This I took heart CT for intention to use the 3D, but at the procedure we realized that this patient was not covered by insurance because the previous ablation there was no ablation at all. It was only
Okay.
EP study, so
Oh.
we just used the EPT catheter
So
and
his back come from where?
just using the EPT catheter.
Okay, so
So
it doesn't matter.
yeah, we could
So,
not
okay, hang on a second now. When they created the map, I assume they recorded EKG, EGMs, correct? Or not? Otherwise, they couldn't create a map,
yeah.
right? Since they got it, you should have looked at it. Okay? The reason I'm asking this is that because you're burning close to his bundle, you really want to burn 1 or 2 times. It's your best chance. Okay? Because you look at how close the his bundle marker and your ablation marker is. So this is a lesson that everybody have to learn. When you're burning around the interseptal area, you really need to understand. That's why even Dr. Park commenting about transeptal left side mapping. Okay? So I would recommend the right side map, left side map, and the coronary cuspid just for your learning when you're doing beginning of this practice. And then when you get good at it, then you can create your own protocol. I'm going to do on the right side map, coronary cuspid, non-cuspid, that's it. Yes, most likely. But then some of this pathway, they embed deep into the myocardial septal tissue, atrial septum. You end up burning high power the way up in the atrial insertion. That can be miserable life because you're going to have a hard time ablating that thing. So I think it is something that you want to make a habit. Whenever you create a map, please sit down, go over the map with your NAVIC or Cartotech, whoever is mapping, and then tell them, show me the earliest point and confirm the EGM. Make sure that EGM is appropriate. Okay? That's all I only ask. This is all learning. And you need to know how to 3D is created as well. Okay? That's all I can tell you. So,
Question.
yes, please.
Go ahead, please.
In this map, we see the white area is just below the his, and it's at some distance from the his. But is it safe to ablate there because the compact node is just below the his? So when we are ablating below the his, how do we ensure that we don't ablate the compact tube?
I think, none of us know where the AV node is. Every single patient with EP study. So that's why we have a cautious measure. Number 2, I personally like to burn in sinus rhythm. As soon as you start having a junction rhythm, you stop. That's the only safeguard you have. HR pacing is good, but then PR's already prolonging is already getting a little bit late. That's why I don't really burn in A pacing. Only pace after the junction rhythm, I pace, and then I watch PR interval. That's been our practice. Actually, this is a US board question in EP. They ask you this question. You got interseptal parahysand pathway, and they show you tracing. Patient is going to sinus to junctional. The question is, what do you do? And they give you 1, 2, 3, 4. And everybody said pacing. No, first thing to stop burning. That is the right answer. Okay? So this is something that we want our fellows practice safety.
I experienced you told exactly the parahysand, the mid-septal back, and it's completely overlapped with this one. So I used transferred above cost and successfully ablated it, fortunately, by 1 or 2 bar. At that time, I used the VPs. I ablated during VPs. But his PR is prone, and gradually prone, and after 1 month, he got the complete complot. It was very sad case, and eventually I have implanted the pacemaker. So even the AOD cuspal approach, it is not safe if it is real paration or mid-septal bypass. So that's why the A-pacing or sinus rhythm ablation is safer to detect the potential, the complot, as early as possible. Dr. Wang,
Yes, sir.
I had exactly similar case yesterday.
Okay.
Patient underwent paration concealed bypass ablation twice in another hospital.
Mm-hmm.
Procedure was done at the non-chronic CASA, like
Okay.
50%. But we could induce the tachycardia yesterday, but just the putting the his bundle quadripolar catheter to make
You bumped it.
yeah, but his bump out.
Yes.
When I use the isoprotol, it gradually shows the VA conduction, but
Uh-huh.
the heart rate goes up, the disappear gap, VA.
Right.
So in that case, how can we map and ablate?
No map, no ablation.
No map, no ablation.
No ablation.
There
We
was
did
a-
exactly, yeah, we did the exactly same thing in Tanzania.
Oh.
That guy put his bundle cat in 12-year-old kid, anti-septal pathway, gone. So we waited about 4 hours, nothing came back.
Oh my God.
So I quit because that kid traveled 300 kilometers to come to this procedure. So it was crazy. But when you do, that's one of the reason I say that especially ladies and the kids, when you do torpedoable anteroseptal, make sure you use a very soft catheter, small caliber, please. Very careful manipulation. Okay. I would not really do adopt 6 French catheter, things like that. No, you shouldn't do that. So, but a problem that I wonder that you can cause bumping this pathway. When Tandoran already, he put his bundle bumped it. That's it. So it was kind of frustrating, but
Interesting
that's what
finding
it is.
the
It's
case.
life. Everybody does that. So
Actually, VA
Uh-huh.
was almost 100 milliseconds, 120
I
milliseconds.
see.
Is it common
Yeah.
in the patient was damaged by fast track?
Yes. No, I think question is that whether there is a fusion bit or not. You did not see his bound potential before the VA conduction, during the VA conduction, or no? Not at all?
Yeah. I saw
Okay.
that. Yeah.
I think it probably already damaged the pathway then. Probably. Maybe a bunch of fiber. Is Edward's paper, he gave 3 sort of updated article about the angioseptal pathway. As far as I know, that guy really does wonderful writing, and I will send it to the fellows paper so they can read about it. He's in Europace actually, and it was 4 years ago I think I read it. But anyway, he talked about all this variation, and then sometime angioseptal pathway even concealed or even manifested more than 2 fibers. So then we bump one, dominant conduction, and second and linger around and cause a trouble. Maybe your case might be that one of them like that. So I think it is something that sometimes they ablate their series of left side as well as the right side. But my thinking is that those pathway better off safer ablator atrial insertion, not the ventricular insertion. So you have to have an effort to find the atrial insertion. We can usually one single insertion. Then you can ablate a high power and then far away, safer from the AV node. You can get rid of all. We see times time.
Professor Wang, I have a question.
Yes, sir.
In this picture, it was this case was long time ago, but I don't exactly remember. But the yellow point was not the his, but the best site at the right side, and
Okay. Mm-hmm.
and every good sites in the right side.
Mhm.
I saw this like near field his
Okay.
signals.
Mhm.
So I consider that right side ablation is too dangerous. So I moved to the cusps, but the
Mhm.
cusp signal was not that good, as good
Yes,
as the right
I
side.
can, I
So
can see that you have a no pathway potential there.
yeah, but I just did it because I considered it was safer, and I anatomically did the counterpart of the best site at the right side. So
Mhm.
is this approach okay?
It's okay, but there's something fundamental concept about the ablating the around the common bundle versus AV node. Common bundle is theoretically already penetrating trigon of a cartilage, and they're covered by the fibrotic tissue. Okay, so they are more resistant to ablation compared to the pathways. So early days, when we start doing this, Professor Jackman did first right next to his bundle, a little bit more distal, and then he ablate 15 watts first. See what happened. And if no junction rhythm, he titrated the power very gradually. But these pathways, anteroseptal pathways, especially when you're bumping, usually very superficial. You can get away with the 25 watt conventional RF. That's how they ablated. But then us, we are not careful as their lab, so we basically assume that teach the fellows whenever they hit bundle, don't burn. But actually, that is not a whatever, in other words, standard practice in the many excellent labs. They do ablate where the his bundle is, but then they are very, very careful. Watching good his bundle electrogram, make sure there's no junction rhythm, there's no AV prolongation, and so on. And a lot of people watching this EGMs, most of the lab doesn't do that. They're just ablating where the delta goes away, where the block goes away. But this is not the one area that you want to do that. Second point is that when anteroseptal pathway, right side insertion, close the bifurcation, right left bundle, recommends people ablate from the under the tracheostomy valve. That invariably will cause right bundle branch block more than 25%. But then you have to make an assessment whether worth making right bundle in someone, young people, versus axillary pathway. Of course, if your axillary pathway EF is very short, high risk of sudden death, that will ablate. But then if you want to do that, you need some special catheter, or you have to use an Agilis sheet, curve catheter under the tracheostomy valve leaflet to be safe. So that way AV node is protected because your tracheostomy annulus is sitting right between AV node and the pathway. But then you only see pathway potential, local V. In this case, it's not applicable because it's not manifest. It's only concealed. So that is an issue. So I will send the article to, Dr. Zhang, and then he can just refer you guys to read it. The time to review the anteroseptal pathway. Okay? It's a good thing.
Everybody doesn't want to see ablate the parasitism the pathway, but I'm sure you will see those patients soon. You will meet. Okay, so one last thing that I would like to recommend, Oyundari, very nice presentation, but when you chose the fluoro imaging and ablation imaging, it's better to RAO, LAO, and ablation catheter imaging put together. Then the audience can understand the right position of the catheter. Okay, any other comments? Question? Okay, thank you very much.
All right. Thank you, everybody. Good job.
You
See you guys next week. Bye now.
Thank you.
can.